Edwards Syndrome Association is a 100% volunteer 501c3 nonprofit organization dedicated to advocacy, equal care, education, and rights of people with Edwards syndrome. The ESA strives to empower parents to advocate while working to help break barriers for those with Edwards syndrome. This podcast is for educational purposes only. For all medical advice, please speak with your medical providers. Thank you for joining us and for breaking barriers with us.
Welcome to the Breaking Barriers podcast, where we talk all things Edwards syndrome, special needs, therapy, disability, and everything in between. I am your host, Crystal Simpson. Each episode, I will be joined by other members of the Edwards Syndrome Association team, as well as our special guest.
Welcome to another episode of the Breaking Barriers podcast. I am your host, Gina Polisek. Joining me today is my co-hosts, Robert and Kelly. On today's episode, we have a special guest who is a neurosurgeon and has done various surgeries on individuals with rare trisomy. We are excited to hear from him on this topic that has evolved so much over the last few years for our kiddos with trisomy 18. At this time, I will turn it over to Dr. Raskin to tell us a little bit about himself before we get into our conversation.
Well, thank you so much. It's a real privilege to be on podcasts like these. It serves such an important purpose as a bridge between, underserved communities, smaller communities, and the medical industry, basically. And it's important for us to be able to share information back and forth that's truthful and evidence-based as much as possible. So I really appreciate the opportunity to talk with you all. And yeah, I'm excited to answer some of these questions.
Thank you. We're so glad that you're here. So could you just tell us a little bit about what inspired you to specialize in pediatric neurosurgery?
Sure. So it was really the children. When you're training, residency is 7 years long, and only 6 months of that has to be with children. The rest is with adults and in various rotations that help you create a well-rounded educational foundation to be able to practice for the rest of your life. And I rotated at the pediatric hospital at Dornbecker Children's Hospital at Oregon Health and Science University about midway through my training. And I met just some of the most incredible children. There were really 3 that stood out in my mind. One was a really terrible brain tumor with no cure, who was just an adorable little boy who wanted to play Legos. So I would play Legos with him. There was a little boy who pulled a TV down on his head back when TVs were actually heavy and large. 2- and 3-year-olds used to pull these big TVs down on their head as they tried to climb the cabinet or whatever. And I thought he was going to die, but he actually did great and survived. And that sort of resilience was very impressive. And then there was a 3rd child who did have an uncommon intraoperative issue, and he had a severe cancer type thing that led to his demise. And just the interaction with those patients, the interaction with those families, it just really crystallized in my mind that I wanted to sort of do this in pediatrics for a living.
Yeah, that's cool. The stories and, stuff that brings you to kind of your lifelong path. But it is eye-opening how minimal the pediatric training is in those areas. Because it's like you have to almost have those moments where you're like, wow, this is the area I want to get into, because it's like you're not otherwise exposed to it enough, it sounds like. And it sounds like that's the same kind of in all specialty areas, not just with neurosurgery, but with, all doctors and specialties and stuff. So it's cool to hear the stories on how people get to where they get and how they end up helping kiddos like ours. So
yeah,
it's cool. So can you just tell us a little bit more about, some of the most common conditions that you treat in children?
I think any pediatric neurosurgeon probably treats hydrocephalus the most. It's a pervasive problem, and luckily we have therapies, but they're mostly from the 1950s and haven't really evolved much. They're life-saving surgeries, but they also, require maintenance. And so I think shunt surgery and CSF diversion surgery with endoscopic third ventriculostomy and other endoscopic approaches, those are the most common thing that we take care of. They tend to come in the middle of the night and weekends, and it's not usually possible to predict when a shunt is going to malfunction. And so that's probably the most common thing. But then a lot of us have the opportunity to subspecialize. And so I, for example, am a functional neurosurgeon. I subspecialize in the three pillars of functional neurosurgery, which are the treatment of chronic pain and end-of-life pain, so pain conditions, epilepsy, and movement disorders. And I do about 150 cases a year in those three pillars.
Okay. Yeah, so like when you say movement disorders, is that like a lot of like cerebral palsy and, people with those conditions that you're treating and stuff?
Yeah, most commonly cerebral palsy. Yeah, I treat, cerebral palsy has a very high incidence in the United States and other industrialized nations, maybe 1 in 500. Um, and there's a spectrum of cerebral palsy, and about 40% of patients with cerebral palsy will have some form of functional limitation, and that, is usually caused by some form of movement disorder, which is an unwanted or limited movement of their limbs. And so I treat a lot of these patients with either intrathecal baclofen, rhizotomy, which is a cutting of nerve roots, deep brain stimulation, pallidotomy. Those are the most common surgeries I do.
Okay. Yeah, and I asked too because I know, well, all of us on this call actually, our kiddos have like a secondary diagnosis of cerebral palsy as well. More, due to the trisomy 18, but I was just curious if you see a lot of people with that. So it sounds like you do. So could you tell us a little bit about when you operated on your first rare trisomy kiddo in whatever capacity it was?
Yeah, I mean, I think it would have to be during residency. So that's 15 years ago now. And, I started as a resident in 2009. And then midway through, so 2013, I was at Dornbecker. And so that's when I would have started operating on children with rare conditions. And it, you know, almost certainly was some sort of hydrocephalus surgery or vagus nerve stimulator surgery for epilepsy. Unfortunately, these rare disorders come with common syndromes like epilepsy. And unfortunately, there's no one focal spot that we can identify usually because it's a neurogenetic condition. It kind of affects the entire brain, and it's not possible to identify a specific spot that we might, take out and then cure the patient. So often these patients have to have neuromodulation, and that's we did a fair amount of neuromodulation for patients with all sorts of neurogenetic conditions as a resident.
Okay. Do you feel that there has been a shift in offering these surgeries? It sounds like hydrocephalus surgery and, like vagus nerve stimulators and stuff have been happening for, quite some time. But what about some of the more invasive type of surgeries? Do you feel like those have shifted over, the last period of time, or, have those been occurring for longer periods?
Yeah, so our approach in industrialized nations, our approach to these patients has really shifted towards more and more life-prolonging interventions. And that includes surgery. It also includes medical management. And it's because of the evolution of medicine, right? And the underlying importance of research that we have placed as a nation, and now is unfortunately being, reversed. But the whole reason why we can be more and more, I want to say aggressive, although it's kind of the wrong word, supportive of patients who otherwise didn't have access to these medical management strategies and surgeries, is because of the evolution of technology, the improved medicines that we have, our enhanced understanding of physiology in complex cases. And so if you look back at basically all metrics in industrialized nations, how many severely premature babies live to be adults, that number has increased, astronomically since the 70s and 80s. And the same thing for patients with rare genetic conditions. What used to be just like you have this rare genetic condition, you're not going to live past 1 year, now has become more of a conversation of, well, with modern medical strategies, it might take a lot of active management in the hospital and outside of the hospital and access tubes and devices to, reduce seizure burden and divert spinal fluid and so on. But these patients can live a long time, a lot longer than before. So there definitely has been a shift in how neurosurgeons approach these patients, mostly because the field of pediatrics has evolved and is able to support these patients for a lot longer.
Yeah, it's incredible how, advanced things have been. So I know you kind of touched on this a little bit, but could you touch on kind of, I know you talked about research and everything, but how has like technology and artificial intelligence and robotics and stuff, helped influence the neurosurgery field as well?
Yeah, this is fascinating. So technology has really evolved. So I mentioned that our shunt surgery is basically 1950s technology, and it is. Now there has been material science improvements. We're no longer putting in, thin, fragile plastic tubes. We're putting in rubberized tubes that actually have antibiotics in the walls of them and so on. So these are a little bit more advanced, but from a technology perspective of, how much fluid is coming through the shunt, we still have no information about that, right? But if you look towards cybernetic devices like vagus nerve stimulation, this is an older surgery, as FDA approved in 1997. Well, we have now two other intracranial stimulation platforms for seizures. One is responsive neurostimulation and one is deep brain stimulation. And these are actually electrodes that go in the brain, and the battery either goes in the skull or battery goes in the chest, just like a vagus nerve stimulator. These are very advanced because they can actually like sense the electrographic correlate of a seizure. So they can sense brain waves and then stimulate that seizure tissue to stop seizing. So that's very advanced. We call it closed loop. And what we can sort of extract from that closed loop system now is a biomarker for seizures, but also for other movement disorders and so on. And this has been done in the field of OCD, obsessive compulsive disorder. So with our current neurosurgical platforms, we're able to sort of start to understand biomarkers, like you might get a biomarker in your blood for diabetes. We're getting brain signaling biomarkers that we can then use to change the behavior of the brain, not people's behavior, but the behavior of the brain. Actually, in OCD, it is people's behavior. Very interesting stuff. And
Yeah,
then we've also got like insane technology for cranial robotics, spinal robotics, where we actually use robotic platforms in order to assist us during surgery to make things more accurate and more efficient. So the application of technology is just um, increasingly sophisticated. And then AI and machine learning, these sorts of platforms allow us to really maximize the inherent benefit of AI, which is logic, and maximize machine learning platforms in order to really process a huge amount of data and give us answers a lot faster and in some cases more accurate than we can just do on our own.
for sure. Yeah, I saw, did Lurie just get like you guys just got like a new kind of like device where you can actually be in there when the surgery is occurring, right? Was that for hydrocephalus or was it for brain tumors?
No, we just opened last week our intraoperative MRI. So this is
That's it.
it's called an IMRIS, an intraoperative MRI suite. It is for any MRI. The only real open intraoperative MRIs that are possible are for neurosurgery. But basically, we can now, and this has been out for a while at other institutions, but we do have it now. It's like a $50 million machine that they had to cut a hole in the side of the building and put it in there. And it's very sophisticated. But basically, it will improve epilepsy and brain tumor surgery because now we no longer have to base everything on our own intuition and surgical sense. We can, remove tissue, and then if things shift and it becomes confusing or we're not quite sure, we can go into the MRI environment, get a picture, and then come back out and continue operating. So it reduces the return to OR risk and improves our ability to get like a complete resection or complete a epilepsy surgery effectively and not injure any tissue that we don't mean to injure.
Okay. Yeah, and it's intriguing how much can be done and how I'm sure compared to even when you started your career, it's expanded so much. Um,
Yeah,
and I
almost.
know,
Yeah, like sorry, I was just gonna say to that point, like most of the things I do, I did not learn in residency. Most of the things I do now, I never did or didn't exist in residency.
yes, you're always learning.
Yeah.
I know you briefly touched on RNS and DBS, which we see, I mean, not super common in our community of trisomy 18, but it's definitely becoming a more, go-to intervention that we are seeing with epilepsy. Can you explain the impact that you feel that offering these surgeries, has on kids with medical complexities such as trisomy 18 and how they help, you know, not just prolong their life, but help them be able to thrive?
Yeah, I mean, they're intended to treat movement disorders rarely, and epilepsy. And so deep brain stimulation and responsive neurostimulation for epilepsy really reduces the seizure burden. Seizures are so harmful to the human brain, and kind of knocks you offline. If you imagine like the brain accessing normal behaviors as getting online, and when you have a seizure, it knocks the patient offline, so they can't ever really do anything. Not only is it stigmatizing and require medicines to be treated and limit your normal development of behaviors, but there's a mortality risk to it in the form of SUDEPs, unexplained death from epilepsy. And so the application of these, cybernetic devices to patients who otherwise previously wouldn't have been candidates is really important. And we're finding that the effect of reducing the seizure burden is actually quite good. And especially when it's combined with a vagus nerve stimulator. We don't really understand why, but there seems to be an added benefit for some
Hmm,
patients.
that's really interesting. And I mean, it's amazing how there's options now, compared to in the past. Um, is there a timeline you would recommend for people with trisomy 18 and other rare conditions to be evaluated, neurologically for conditions such as hydrocephalus, or epilepsy, or really any of that?
So hydrocephalus is a clinical diagnosis that typically is made in young children. It's rare for adults to develop hydrocephalus, but it does happen. I think that if, in patients who are young, hydrocephalus can look like several things. It initially can look like a growing head, separating sutures, bulging fontanelle, and then after that, as the head closes, it can look like, recurrent vomiting syndrome. It can look like neurological deficits or just like the stabilization or even decline in the ability to gain behaviors, new behaviors. And if that's happening, I would go to a pediatrician, and ask for a cranial image. And it doesn't have to be a CT of the head, but some sort of cranial image, and then be seen by an ophthalmologist, an eye doctor, to look for swelling of the optic discs. And that's typically how a lot of these patients get to neurosurgery, is because their neurologic exams are very easily interpreted by their caregivers, but not so much by medicine. And so we have to have these adjuncts like eye exams and imaging in order for us to sort of get to the diagnosis of hydrocephalus in these patients. And then epilepsy is very well defined. You would see a neurosurgeon if you have seizures, continued seizures, despite two appropriately chosen and adequately trialed medications. And these are international guidelines from the International League Against Epilepsy, which I love. It sounds like a Marvel superhero group. Um, and that's where the definition for drug-resistant epilepsy comes from. And those are the patients we operate on. We don't operate on a person who had a seizure. We operate on people who have epilepsy syndromes.
Okay, yeah, that makes sense. Yeah, certainly, epilepsy is common in trisomy 18. Um, so it's something that our organization does get questions on frequently is, my child had a seizure. What should I do? But then, we get questions on, I think they may be having multiple seizures. So it's always good to kind of know, how to guide people. And as parents too, obviously we've kind of been through it with our own kiddos. So we also go off of our own experiences most of the time, but I know it's also helpful for parents too to sometimes hear from experts and kind of what their recommendations are, in those moments as well. So thank you for that information for, people that might not know to go to an ophthalmologist if their child's doing, something weird neurologically. You know, there's a lot of things that you just don't think of until you
Right.
have to, if that makes sense.
Yeah.
Um, so kind of switching gears a little bit, what advancements in pediatric neurosurgery are you most excited about? I think you've
Um,
kind of expressed it a bit, but if you could answer it directly, I guess.
yeah, I mean, I think, one of the most exciting things is application of machine learning to increase referral patterns. So what we know, for example, about epilepsy is that there are so many more patients who have drug-resistant epilepsy than ever get to the epilepsy center. And it's because of a combination of things. A little bit of it is patient and caregiver hesitancy to go see a neurosurgeon. So we try to destigmatize ourselves as much as possible, but we're still scary people, I think, to most of society. But the other thing is a lack of education of the referring providers that, two or more appropriately chosen, adequately trialed medicines and a patient still having seizures, that person should come see the epilepsy center and get evaluated. And there's already been some successful studies from Cincinnati and other places where they actually used machine learning algorithms to send alerts to providers that their patients need to be sent to the epilepsy center. And it increases threefold the number of people who get evaluated for surgery and have surgery. And then the benefit of that is that they are either seizure free or they have a much higher chance of having seizure reduction or being a responder versus people who don't get seizure surgery. So, that's a very exciting area. And in general, there's so many people we can help, and we just never see them in clinic, unfortunately. So that's very exciting. And then the other thing that's really exciting is the increased technology that's coming. And in the near future, we will have sort of many more biomarkers and a better understanding of how to treat epilepsy, and so maximizing this technology to improve people's quality and quantity of life is going to be, astronomical in the next couple decades.
Kind of dovetailing off that, Dr. Raskin, are there areas for improvement in regards to those technologies? And I know there always are, but what are some that kind of come to mind? Like earlier, you mentioned that there's not really a way to track like the rate of the fluid coming from the brain. Is there a way to kind of advance in that regard, or even in the epilepsy center, either hydrocephalus, epilepsy, whichever way you want to take this question, essentially?
Yeah, absolutely. Thanks. So there are many industry partners who are trying to create a quote smart shunt or have like a device that you could put over the tube and understand the flow. So you can kind of correlate flow with behaviors and know before a shunt fails and the patient's very sick and needs emergent surgery, you can tell, oh, this shunt is working less and less well. And then like the micronization of chips that can go into a shunt and give you real-time information. Those are being worked on, and hopefully in the next, decade, they will be FDA approved for use. And then the devices, they're all adult devices that we put in children. The only one with an FDA indication for children is the vagus nerve stimulator, which was FDA approved in 1997, initially not for children, now is approved 5 and above. and we put them in, anyone. We can do whatever we want without FDA approval. It's called off-label, and we do, right? All the deep brain stimulator platforms, all the responsive neurostimulation that we put in children is not FDA approved for children. It's FDA approved for adults, and we use it in children. But when you do that, you're putting adult size hardware in little kids, and so the complication rates are a little higher. And then so if in the near future we had, child-sized devices, spinal cord stimulation, and all these things, then that would be better to integrate into little tiny bodies than adult-sized hardware. And then the devices, they currently have batteries that expire. So improved battery technology will allow people to have fewer and fewer surgeries, less risk to the patient, less risk of infection, and so on. And then, like an RNS and a DBS, these are 2-port systems, so you can really only have 2 electrodes in place. So they're developing 4-port systems, so we can actually put more electrodes in and create more circuits that will be better to change, abnormal brain activity. So those are the main things. And then, of course, the integration of AI into these devices so that the device can not just recognize a single waveform and stimulate, but it can know that, it can just know that based on this monthly cycle, this is the brain activity, it's about to ramp up, and then, they can use that electrical dosing a bit more effectively.
Yeah, it's interesting. So it sounds like there's definitely a lot of improvements needed in the hydrocephalus world, but hopefully some are being worked on. From what you're saying, I mean, as a hydrocephalus mom myself, I think that what you said with where you can actually put it over to see how the spinal fluid is, draining would be incredible. Because
Mhm.
I mean, we've been through it where it's like, is this actually a shunt failure or not? And you can only go off of the symptoms you're seeing, and ophthalmology helped a lot in our case, but it's so complicated and it's
Yeah,
stressful, I'm sure, on you, and then also like the parents. It is so stressful to be like, do we take them in because do they have a UTI or something else, or is their shunt failing? So it's incredible to hear that there's hopefully steps being taken to hopefully resolve that. It stinks to hear that it could be still another decade out, but hopefully maybe we'll get lucky and it'll happen sooner than that.
Yeah, it might be sooner. It's just the FDA process takes a long time. But I know that the company I've been sort of consulting for is pretty far along. So stay hopeful.
Yeah. No, we have a lot of hope around here. It's
Yeah.
kind of what we thrive off of hope.
Yeah.
So it's actually just cool to kind of hear, different things that are, being researched and looked at, to keep advancing a lot of these things. Um, so super, super interesting. Did you have something to say, Robert, before we move on to the next topic?
yeah, I just wanted to kind of continue on with that smart device that you were touching on. Would it is the thought process kind of like dovetailing off of like the VNS, but not maybe from a magnet standpoint? Is that kind of the thought process that the team that's working on it is kind of working towards on how that would kind of be gauged and whatnot?
Yeah, the shunt
The
monitor.
smart shunt, yeah, that you were
Yeah.
talking about. Yeah.
Yeah, well, there's a variety of companies working on a variety of solutions. One that's really exciting is really for home use, and it's
Oh,
potentially you could upload this data to, a chart that your physician could look at, and it would give some sense of flow. Um, I guess it would give some sense of functionality, whether or not that's flow or volume,
yeah.
is still up in the air, but it is sort of like like the vagus nerve stimulator, you can use a magnet to swipe it and it will
Mhm.
stimulate the device, right? This is not a device that can actually change the functionality of the shunt, but it can measure the functionality of the shunt and give you
Got it.
some sense for your child, what is it doing? Is it like less flow, or is it the same amount of flow, or whatever?
So it's more in line with like a home EEG type of system where it's not like detecting like the brain wave, but it's more so a device that can detect, like you said, the flow of the brain fluid and whatnot.
Yeah.
And as Gina touched on, that would be huge in regards
Yeah.
to less hospital visits and even over very family oriented holiday seasons and whatnot, would
Yeah.
be very beneficial for sure.
Absolutely. Yeah. And you do have to be careful in this space because there was a catheter that got marketed and sold in a variety of places, and it was like it promised that it would, if you pushed a button, like if you pushed on the shunt, then you could expel fluid through the shunt tube and save the patient from an operative experience. It never really worked great and didn't get really picked up. And unfortunately, like this gets marketed to families who then want it, but then insurance won't pay for it. And then it just doesn't have the evidence to support its use. So this space really has to be well regulated. You wouldn't want to develop a device, for example, that had a high false negative rate and,
Yeah.
reassured you, incorrectly that things were fine and then have a problem, delay in care and so on. So it is very important that these systems are like fully supported and investigated by, credentialed people and not just sort of sold, at market value.
Absolutely.
Yeah, it's just incredible how, I mean, even just with the VNS, how they can swipe it and then it takes all of the data to like the iPad and they can set like when it goes up next and like the titrations if I'm using the proper verbiage. But it's just it's incredible like how far technology has come with some of these systems and all the things that are being researched and looked at to improve some of the other things that could use some improvement like hydrocephalus.
Mhm.
So it's fun to hear those things, and I'm sure you're very I'm sure it's very exciting to you.
It's very
Um,
exciting because, yeah, these patients, they have like, from a VNS perspective, VNS is the most palliative surgery we have, but it still has an 8% seizure freedom rate, which means that 8% of patients implanted with a vagus nerve stimulator will never have a seizure again. And that is 3 times higher than adding a third or fourth or fifth medicine to the patient's regimen. And then also the responder rate for vagus nerve stimulation is 50% or so. And so that means at least 50% of patients will have a 50% reduction in seizure burden. And there's no other sort of medicine that will be as effective for that population of patients. And it's a pretty straightforward surgery, and patients generally do pretty well. So yeah, even our most palliative approach for treating seizure disorders is 3 times better than any other medical strategy.
yes, and certainly less medications, the better.
Mhm.
That's kind of what we've learned, especially recently. So it's yeah, the vagus nerve stimulator is a great tool for sure. What qualities do you think are essential for someone in your profession, especially when it comes to treating people with, more complexities, such as Edwards syndrome?
I think, uh, hmm. I mean, all doctors really share this sense of compassion, I think. I mean, I guess all good doctors. There's probably a bunch of people who don't, but
Yeah.
um, I think an overwhelming sense of curiosity and compassion can really help tremendously, because it helps you recognize what people go through on the other side of medicine. Being on this side of medicine is way better than being on the other side of medicine. And so if you can maintain some compassion for people who are going through it, it will really, uh, you know, facilitate this human connection, which is really all that medicine is. And then I think a sense of curiosity helps you understand that, we do not know everything. We actually know like this much of like this, right? Um, and so recognizing the limits of knowledge and what is actually possible is a really important part of being a neurosurgeon, I think. So, I try to recognize that people are complex, especially Edwards patients and other neurogenetic conditions. They're so complicated and they're outside of normal physiology. And so, a lot of stuff is possible. And also it helps you recognize that, as a doctor, we're basically a tourist in your life. We don't live there. We don't see the patient every day all the time. And these caregivers do, right? So a sense of curiosity will help you extend the diagnostic capabilities to the caregivers when you can really sort of lean on their observations in a lot of cases and say, look, what are you seeing? And if you don't stay curious, you're not going to be able to do that.
For sure. No, and I mean, as parents of somebody that you've helped, those qualities you said are exactly what we've noticed in you too, is like you really lean into the parents and, want to know what they're seeing and you trust their judgments and, it's so important. So you actually answered that question, exactly as I probably would have anticipated you, answering it. So I feel like it's definitely essential, when dealing with, more complex people. Um,
Well, I was actually
and
going to add as well, the fact that ever since we walked into our first consultation with you for Mia, it's always been very conversational and very team oriented,
Yeah.
which we have realized through our path of working with many specialists like yourself. That's when we see the most benefits for Mia. And exactly what you stated, that's where the compassion and the education comes into play, is that we don't know everything. We're coming to you as the specialist to learn more about our daughter, to then take back and be able to have more beneficial home life. And as you said, your recognition of just your small little piece of our puzzle for Mia, essentially, and your understanding of that has been able to have her be so successful in all the things that have come up in the last 2.5 years since we've connected with you. So we're grateful that there are specialists like you to not only, kind of have your specialty, but also your willingness to understand and kind of put yourself in our shoes as well. And that's where I also feel are the best caregivers like yourself.
Mhm.
So I just wanted to thank you for that, but also just kind of add some additional color to, our own story
Yeah.
for that in regards to what you mentioned as well, because you definitely facilitate what you just spoke.
Yeah. Good. Thank you.
So kind of going off of that, and I think we've kind of touched on it a bit, but what advice would you give to neurosurgeons that are interested in helping kids or people with rare trisomy, but maybe haven't to this point?
It's incredibly rewarding to help patients with rare trisomies and neurogenetic conditions. And it will test the limits of your understanding. So I would say just do it, it's definitely worth it. The way modern medicine works, it is a for-profit sort of fast food model, right? You get paid a certain amount of money and you need to see a certain number of patients, right? And so it really requires an academic atmosphere to sit and think about complicated patients. And so what that means is that if you are a person in the community with a complex child, it's going to be very hard for you to go from private practice person to private practice person and get a level of care that you're going to get at an institution where everybody has a different reimbursement model, or where everybody is able to really sit and think and communicate with each other. So I guess that's a message for families is it's really important when you have a very complicated child that you find a group of clinicians that you trust in an institution you trust and stay at that institution. And a lot of times we get people who are, they go here for ENT, they go here for GI, they go here for this, and it's very hard to communicate across institutional platforms. In fact, these institutions hate each other, and they're not able to share information, and it's really hard as a clinician to sort of get a comprehensive understanding of a person. So that's something that makes our job technically very difficult. And I think can adversely impact the child. But from a physician perspective, I would say that, these are really rewarding cases. Like when you can take a child who's been sort of marginalized, and already has so much to overcome, and they've been marginalized because they're so complicated and people don't have the time or effort level or motivation to sort of take care of them, and you can intervene and change that person's life and that family's life. That's like why we all went into medicine. So I would just say, try your best to sort of have these patients come see you in clinic.
For sure. No, and it's interesting your comment too about trying to stay within, like one kind of institution. I feel like it's really difficult as parents too.
It
I
is.
mean, 'cause in our case, like we're at a few different, but you made a very good point because kind of dovetailing off of that a bit, when Mia was hospitalized recently, and she had the neuro issues, which led to some like cardiac concerns. It's not that it was difficult to manage it, but we kind of realized that if her cardiologist was where we were, it would have been, a little bit easier. And I mean, thankfully the stars aligned and we actually met a cardiologist that is going to be an amazing fit. And he was willing to take on her as a new patient. So it doesn't always work that way, and it's really hard to change sometimes. But
Mm-hmm.
you definitely do sometimes have to start thinking about what makes the most sense. Like if your kiddo is going to have, you know, things occurring and it's going to lead to something else, does it make sense to start thinking about trying to get some of those specialties under the same roof, just to simplify it. So that's a very good point, and it's a very tough one as parents with complex kiddos because you really just like you start to trust doctors and like say for you for instance, if you were to switch hospitals and go somewhere else, like our gut instinct would be like we need to go follow him, because like we
Yeah.
trust you. So like that's where it gets so complicated. But it is definitely very important to find a hospital system that you trust and hopefully can kind of grow with you. And I mean, we've been blessed to find that within Lurie recently over the last couple of years. But definitely a conversation that could probably go on forever. I feel like you wanted to say something, Kelly, so I'll let you go ahead.
My daughter's in three different hospitals. Um, most of it is in one now, but my trust, like Gina said, with like her cardiac is in DC.
Mm.
So I'm not taking her from there. Um, they saved her life when others refused. And they've been excellent with her. Even though where she goes elsewhere, they said, "Oh, we'll take her." But it's just I can't.
Yeah.
And
Oh, I get it.
you get that trust and it's like, you know,
Yeah, you find the amazing people like yourself, and it's
yeah.
it's hard because like even though like all the other neurosurgeons within your group are awesome and great too, I'm sure. And I mean we've experienced another one ourselves even when Mia went in the day after Christmas, but you just like you really start to cling to kind of like who knows your child best too.
Yeah.
But it's definitely a very interesting topic because it is very important to stay.
I mean, I get his point because when she needed to have hip surgery at up at Nemours, they had to get everything cardiac, you know, to where I guess what is that? Where they had to be like free to do it because her cardiac's fine.
Parents, yeah.
Um, and they had to get it from her cardiologist who was in a different hospital. So it took a little time. Like I get that part, but
Yeah,
Yeah, it's a
it certainly
complex
complicates
topic.
it.
I think it's worth
yeah,
talking about. Like, what are some strategies where we can improve the sharing of information? Because I totally get like you go to one hospital and someone takes you seriously and takes care of your child, and it's hard for you to like violate that trust and go to someone else and have the same understanding that that person is going to help you as much. So I get
Mm-hmm.
this sort of affiliation with different doctors and clinicians in different institutions. But also, it's true that it's hard for us to share information from one place to
Yeah.
another. And so, what strategies would we use? There's a couple that I know, like the CPRN, Cerebral Palsy Research Network, has an app, and that app can interact with a bunch of different information sources. And so it's possible for a person to come to clinic and say, like, this is what my orthopedist said, this is what my physical therapist said, this is what my neurosurgeon said, and it's all in their app. That's a good way. Um, but what other ways would you suggest to sort of more effectively share information across institutions?
I mean, if they're on the same computer system, are they able to see everything? Because we go to 3 different ones and they can see everything.
Hmm.
Like, oh yeah, we saw that if I like mentioned something.
Hmm.
So, and I think the big one here is Epic. But so I guess that's why it's been a little easier with her because they're all in the same system.
Hmm.
But
Yeah.
Yeah, I know here in Chicago it's a little more difficult because even though there's a plethora of large hospitals, specifically even in just downtown Chicago itself, but there's also sister hospitals and different affiliations with those sister hospitals that you mentioned that like it's literally like a rivalry between them. And if you are actually at the rivalry one, it's very difficult because they're never going to pick up the phone. What we've
yeah,
gathered is that the best case scenario is having the specialists like you that are willing to simply directly communicate with the other individual.
Right.
And ultimately, what we've gathered is there's sometimes too many cooks in the kitchen and too many levels to get to specialist to specialist communication. The ones that, and I think the app is a great step forward in thought process of simply having the specialist willingness to say, okay, your cardiologist is at X. I mean, you must trust them
Mm.
because even though like they're the Packers of the Bears, right? But I know you're not a sports guy, but I had
Yeah.
to make a reference in some capacity. And so to like, okay, we're still gonna make that call, but let me do it,
Yeah.
and just have that willingness. I think that's the toughest part that we've noticed that there aren't a lot of specialists that are willing to do that. And so that's where some of the hang up is. And then once that's actually done, it's amazing how quickly things actually get completed because once that
Yeah.
connection is made, it's instantaneous. And basically, kind of where Kelly was touching on is that if there's that software already available, like that helps. But ultimately, what's the best and the most immediate form of communication? Just picking up the phone and talking to somebody.
Yeah.
And ultimately, that's the quickest way to things to get done sometimes.
Yeah.
And I think too, it's like kind of going back to what you said, Dr. Raskin, I'm sure a big deficit that you see is actually getting a hold of a specialist from another hospital is probably, well, we know it's tough. And so I think in those situations, it's like you can make the call, leave the message, hopefully you can connect at some point. But like I know one time actually Mia was at a different ER because unfortunately the ER that you're at is twice as far. So it's like you also have to make those decisions too in those critical situations. Like, can I safely get her there or do we need to go somewhere else?
Right.
And I know that you were kind of playing phone tag with the ER. And so you actually, your nurse, I believe, sent me a message and said he can call you in 10 minutes. And we didn't have service in the ER. So I actually went outside, waited for you to call me. You called me well within that 10 minutes. We spoke and you just kind of wanted an update on what was going on and reassured me that like you felt it wasn't likely her shunt and things like that. So like I also think that, you know, like the good specialists like yourself in those situations too, like if you're struggling to get a hold of the hospital system that's taking care of the child at a different institution, you know, try to communicate as best as you possibly can with the parents, you know, whether it be via my chart or, you know, seeing if you can get a hold of them by phone and, you know, trying to have a plan there too. Like, you know, I'm working on getting a hold of them, but like let me know what's going on too so I can, you know, like there's avenues in that way too. And I feel like you probably don't even remember that happening because you deal
I
with
do
so
remember it
much,
actually.
but okay, well, that makes me feel good. But I mean, that's like, I certainly remember that. And then I was like, okay, like he reassured me that this likely is not neuro related, and it wasn't. It was a UTI and an ear infection, I believe. But once I spoke to you, I, had that reassurance, and then I was like, okay, we can wait until like your department can connect with them. Um, so yeah, certainly a complex topic that we could probably have a whole entire conversation and
Yeah.
podcast episode on. So we can kind of leave that one there, but
Yeah.
definitely good viewpoints from both, your perspective as a provider, and then,
I think with
parents as
me,
well.
before you like go somewhere else, because I've been in the medical system my whole life because I was born with congenital heart defect.
Um,
And my thing to how the emergency room that I went to, because it was closer and not to where my cardiac care was, is to make sure that the patient or the parent has a either on-call number or like a quick way to get a hold of you as a doctor, because that has helped when I'm in the emergent situations, because with what I have, it's one of the severe ones. The local hospitals are like, what do I do? So I always was able to give them that information where it was immediately to my doctor, and then my doctor told them what to do.
yeah.
Or, and that's helped in many situations too. That's one of the things.
Yeah,
Yeah,
I just
that
want to,
make sure you're available as much as possible is
Yeah.
a great
yes.
patient care tactic.
Yeah, and in our case too, actually, the epilepsy center. So when Mia goes via ambulance, she goes to an adult hospital, and level one trauma center, great, but they just don't deal with kids enough, especially complex
Mhm.
kids. And so the epilepsy center actually put together like a whole emergency plan for Mia that goes well beyond like just like the seizure, give her rescue med at this time and call 911. Like it's like when she's in the ER, they're going to give her this medication and do this and contact this person. So I mean, there's also avenues to do stuff like that for, like the more kind of complex situations where, you need to act quickly. So yeah, I thought I would mention that, going kind of off of what you said, Kelly. So to kind of change gears, just a couple more questions here before we can wrap up. But how do you manage kind of the emotional stress of working with critically ill children?
Yeah, I mean it can be emotionally taxing, especially when patients aren't doing well. Um, we tend to compartmentalize, and that protects, your emotional state. We tend to use logic a lot. So, think about problems instead of feeling the
Mhm.
consequences of those problems, although that's not always possible. And then, we always attempt to take good care of ourselves. It's hard to get sleep as a provider, just like it is as a mother and father. But I think as much as you can, take care of yourself, get sleep, exercise, do all the things that help you offload stress. Um, for me, I work out and I hang out with my wife and we go on walks and sometimes yoga, though I'm not very good at it. That sort of thing. And she's a very good influence about going to sleep early. So those sorts of things. It's really hard when you have a sick patient or when you've caused a harm to a patient. Um, that's really hard to deal with. And I think that in that case, you sort of rely on your colleagues and your trusted mentors to kind of help you get through that.
Yeah, that makes sense. Um, yeah, I imagine it has to be pretty tough too to, see that, every not hopefully not every day you're going to work, but just, having to deal with the bad things that happen. I mean, we see it in our community, and we kind of have to deal with those those feelings and everything of, seeing other kiddos go through stuff. And, so I imagine it's probably similar when, you're seeing that, and, they're not your children, but you get that relationship, and,
Oh
you
yeah.
have those feelings. And I feel like, from my personal perspective anyway, I think the best providers, I'm sure you try to like detach a bit, but also like the good providers do still have, some attachment to their patients because everyone's human. So it's like
Yeah.
if you don't have those connections, it's like what are you doing? You know what I
What are you
mean?
doing
So
there?
so I imagine that the emotional stress that you feel sometimes has to be pretty taxing. So
Yeah.
thank you for answering that question. I know you've kind of touched on this a little bit too, with like talking about like Cincinnati's advancements and stuff, and we're well in tune with Cincinnati because they're actually, I would say, probably right now they're probably honestly like the leader for trisomy 18 actually, and kind of just the amount of patience they have with it and just some of the things that they're doing. So we've connected with various doctors there and stuff, and they're doing a lot in that space, so I can imagine they are in many spaces.
Mhm.
So I know you mentioned them, but how do you collaborate with other professionals to continue to advance, and stay as a leader in the space of neurosurgery?
Well, that's a good question. I mean, so we go to a lot. So we publish in academics, you have to publish. It's like publish or perish. That's like the phrase. So we perform research on our own. We look at our own case series, and sometimes we form collaborations with other institutions. We look at a bigger group, like for example, trisomy 18, very rare condition. So I'm only going to see a handful, right? But my partner in Cincinnati is going to see a handful, and someone in the sick kids in Toronto is going to see a handful, and we pool all our data together, and we sort of derive conclusions from those groups. So we work together closely in research. And then we also go to conferences. We go to a bunch of conferences. I think I'm going to 15 conferences this year. And they're all throughout the world. I'm going to Brazil, Lyon, France, Poland. I mean, it's in a bunch of places to sort of share information with clinicians around the world. And so that's how we keep our sort of, understanding as timely and sort of innovative as possible. I can pick up the phone and call pretty much any neurosurgeon in the world, and it is really cool to be able to do that. There's about 200 pediatric neurosurgeons in the U.S., and there's a few thousand in the world. There's 5,000 adult neurosurgeons in the US, and there's, I don't know how many adult neurosurgeons in the world, but it's not too many more. And when you have a difficult patient, it's really nice to be able to say, I read this person's paper. I know they're literally a world expert on this one thing. I'm going to give them a call. So that sort of thing is facilitated by research and then multi-institution collaboration and then also conferencing together.
Yeah, it's crazy to think. So there's only 200 pediatric neurosurgeons in the US. I mean, I guess that makes sense, but wow, it's crazy when you
Think
actually
about how
hear the number.
Yeah,
I
just
can
think
tell
about how
you this as
special
a
your Rolodex and your contacts list is in your phone. That's pretty impressive.
Yeah, it's cool. I mean, it's nice to be able to. They're probably there are probably maybe 250 or 300. There's 200 in this group that we're a part of called the American Society of Pediatric Neurosurgeons, and we all get together once a year. We try to all get together once a year. We have an annual conference, but not everyone can go every year, is my point there. But
yeah.
yeah, it's a small population of fellowship trained pediatric neurosurgeons.
It's like
That's
that.
really
Well,
cool.
obviously, you would know in the cardiac surgeon world, it's like that
Yeah.
because my surgeon who did my surgeries, the surgeon that I saw when I was pregnant was his partner that I didn't know. And
Mhm.
then the one who actually did her surgery was my surgeon's roommate in medical school. So I was like,
Yeah.
that's when I
Small
realized
world.
how like small all the surgeon worlds were.
When you get up to the very highly sub specialized surgeon population, then there's only a handful of those people.
Hmm.
Yeah.
Yeah. Well, it certainly makes us honored that you, of, the 200 to 300 neurosurgeons in the US,
Hmm.
wanted to take the time to come on here and speak to us, about our kids and trisomy 18 and, trying to advance their care. So I mean, we're very grateful for that. On that note, I don't have any other questions or topics for you. Is there anything else that, you feel you want to, state or anything before we wrap this up?
I really appreciate being able to come on here and see you all on a Saturday and talk with you. It's been my pleasure. So thanks a lot for that opportunity. And I hope I only see you as an outpatient.
Yes, yes, that's always the hope. We don't want to see you more than that, and
Yeah,
unless you come on things like this, we'll see you then.
right.
But yes, we really appreciate your time coming on here and your expertise and sharing that with us and our community. It's greatly appreciated.
Good.
Yeah, we're very
Yes.
grateful for all you do, Dr. Raskin. So thank you very much, and your willingness to come on this podcast and bring that 1/200th knowledge to our platform. We're very grateful. So thank you very
Yeah,
much.
my
Yeah,
pleasure.
because it's amazing to hear what's going on. Like, it's awesome.
Yeah,
Yeah,
now and in the future, it really is.
Yeah.
So thank
yeah,
you.
no problem.